Today, we convene this hearing at an important time when healthcare remains at the forefront of our minds as we attempt to move past the COVID-19 pandemic. We faced a number of challenges with wave after wave of new variants, and we continue to confront the challenges of new variants to come. But I'm hopeful that we're finally making progress in emerging from this pandemic with a better understanding of the virus and with more tools in our toolbox available to fight its effects. And the fact that we're all here in person today is a very good sign of the progress that we have made. Welcome, IHS Acting Director Elizabeth Fowler. Good to have you, as well as IHS Chief Financial Officer Jillian Curtis. Good to have both of you here today and for your willingness to answer the questions that the senators may have. I look forward to hearing from both of you on how a combination of fiscal year 2022 funding and previously appropriated supplemental funding is being used to address the pandemic's ongoing impacts in Native communities, how we are working to improve patient outcomes, how bipartisan infrastructure funding will make an impact on water infrastructure, and most importantly, how we are planning to deal with future healthcare challenges with your agency's proposed fiscal year 2023 budget. Native communities have been disproportionately affected by the COVID-19 pandemic, with Native COVID mortality rates twice as high as non-Native populations. Native Americans and Alaska Natives have been hospitalized due to COVID complications at a rate 4 times higher than non-Hispanic white individuals. Unfortunately, these differences are not uncommon even outside the context of COVID-19. These disparities in healthcare have long existed. The pandemic simply highlighted and exacerbated them. So the work to improve health outcomes for Native American communities remains a vital challenge that we must tackle. To that end, this committee provided Indian Health Service with $6.6 billion in the fiscal year 2022 omnibus, a $394 million increase in the agency's funding. These increases were provided in the hope that we can move the needle towards bettering the lives of Native Americans. This is not only a moral obligation, it's a trust and treaty responsibility that we must never lose sight of. We can never fully atone for the sins of the past in this country, but we can and must do our best to live up to our responsibilities providing the best available health care as enshrined in treaties. Because no matter who you are or where you live, health care simply is and ought to always be a fundamental right in America. I am pleased to see the Biden administration shares this commitment and is proposing significant new investments in the Indian Health Service. The request includes $9.1 billion in funding for fiscal year 2023, or a $2.49 billion or 38% increase. And for the first time, the request includes a proposal to move IHS from discretionary funding to mandatory funding. I am keeping an open mind on this proposal and look forward to discussing this in more detail in this hearing during our questions. But I'll say right now that I agree with the sentiments to want to provide financial stability to the agency and to Native communities. And I'm pleased to see ideas being proposed to prompt discussion on how we can address chronic problems. I do have concerns, however, that despite the significant, important reasons to change the funding trajectory, we need to also make sure that there is an important congressional oversight role. And so how do those two pieces fit together, the possibility of mandatory funding and congressional oversight? I think I speak for most, if not all, of my colleagues on this committee when I say this is something we are not easily willing to forego. We feel that annual appropriations is an important tool for ensuring close oversight and a close working relationship with agencies and the programs we oversee. We need to learn a lot more about how this proposal would work, and I look forward to having that detailed discussion with you in the near future. I am pleased to see a proposed IHS facilities request of $1.6 billion, an increase of $626 million or 67% for tribal infrastructure, medical equipment, water infrastructure investments to improve access to drinking water and clean water systems in Indian country. This investment in water infrastructure is critically important for the health and well-being of any community. The water infrastructure funding provided for fiscal year 2022 comes on top of the $3.5 billion that I'm proud we're able to provide for tribal water systems in the bipartisan infrastructure law. There is a direct correlation between improved water and sanitation systems and improved public health. The infrastructure funding was, frankly, an astounding level of investment. It cleared out a backlog that we know will soon be replaced by other projects that are desperately needed by other Native communities. I look forward to hearing how all of this funding is being spent and how we can continue to focus on these investments. In Oregon, for example, the Confederated Tribes of the Warm Springs has 57 miles of pipes in such a state of disrepair that much of the community is repeatedly left without running water and are under almost perpetual instructions to have to boil their water to make it safe to drink. The system is operated by a computer that was salvaged from a landfill. It's running on a very old and unsecure version of Windows. It's been obsolete for many years. Just a symbol, if you will, of how out of date this infrastructure is, how much it's in need of restoration. In 2022, these are stories we shouldn't be hearing about in the United States of America. We must do better. So there's a lot to discuss, and I'm looking forward to that conversation. And now I'd like to turn to our ranking member, Senator Murkowski, for any opening remarks that she would like to make.
Thank you, Mr. Chairman, and good morning. Good morning, Ms. Fowler. It's good to have you before the committee here this morning. We had an opportunity to have you before the Indian Affairs Committee last week, so I appreciate you coming back to the Hill, and an opportunity to discuss the FY 2023 budget proposal. Mr. Chairman, you have noted the issue about or the decision that has been made by the administration proposing to reclassify the entire agency's budget. And so I just want to thank you for having a hearing on this proposal, because given that we're looking at this proposed reclassification, to put the entire agency budget for FY 2023 as mandatory, really the 2023 IHS budget proposal is technically not under jurisdiction of the Appropriations Committee. So I'm glad that we are having the decision to move forward with this hearing despite some jurisdictional issues. Well, we're not completely back to pre-pandemic level of activity. I am hopeful that we've turned the corner on COVID. Over the course of the pandemic, IHS received approximately $9 billion in supplemental funding to address both pandemic-related expenses and other long-term infrastructure needs like electronic health records, information technology. And in addition to the investments made by COVID supplemental packages, the bipartisan infrastructure law enacted last year dedicated $3.5 billion for the IHS to fund all listed wastewater and sanitation projects, as the chairman has mentioned. I have consistently raised this funding as a priority in our hearings, so it's no secret that securing the money to address the IHS backlog was something that I worked really hard on to make sure was included in the final infrastructure package. We've heard about potential administrative cost concerns associated with these funds, so I'll have some follow-up questions related to this in our back and forth after statements here. When you consider the COVID supplemental packages, the bipartisan infrastructure law, and the annual appropriations bills, the IHS has received approximately $37.5 billion over the preceding 4 years. I think that this demonstrates our commitment to working together in a bipartisan manner to address our shared tribal priorities across the board. Whether working together to navigate the budget unpredictability and instability surrounding the 105L issue, providing money to fully fund staffing packages, or trying to address the overall needs of the entire health delivery system while also taking into consideration administration and congressional interest during a pandemic, I think the work has been together, and that has been so important. When I became chairman of this subcommittee back in 2016, the annual appropriations level for the agency was $4.8 billion. An indefinite appropriation for contract support costs was created in my first bill as chairman. Tribal lease payments were not a significant portion of the budget, and one of my priority issues, sanitation construction, was funded at $99 million. Last year, in FY22, the agency received $6.6 billion. In 7 years, the IHS has received an approximate $37.5 increase in programmatic funding, while the overall allocation of the Interior Appropriations Bill received an estimated increase of 15% over the same period. So I think it's important to recognize that this could not have been accomplished if IHS was only my priority. This had to be a shared priority, and it clearly was. The increases the IHS has received relative to the overall increases for the Interior Bill clearly sends the signal that this agency is of bipartisan, bicameral importance. And the fact that this subcommittee provided significant increased funding to the IHS, even during times of budget constraints and caps, should indicate that we are all dedicated and all committed to ensuring access and quality care for Indian country. So in light of all of our shared accomplishments, I was disappointed to read the 2023 budget proposal. Last year, the administration proposed advance appropriations for the entire agency, as well as a budget reclassification for the contract support costs and the highly unpredictable 105L tribal lease payments. Advance appropriations, as you know, Ms. Fowler, is something that I have personally been supportive of over the years. I also know that when this concept was proposed in the budget last year, many of my colleagues and staff had technical questions that went unanswered, unfortunately, and unexplained for months. This delay likely contributed to the omission of this concept in the final omnibus bill, but I was hopeful that those conversations would have carried forward in an effort to potentially set us up for success for at least some accounts in FY23. But this doesn't appear to be the direction that the administration took. Not only does this budget proposal fail to take a lessons learned approach in an effort to be successful, this budget proposal takes a serious conversation, and I think it makes it less serious, which is disappointing. Another area of concern is the recent actions of the agency related to contract support costs. As you know, a large number of tribes and tribal organizations are concerned the agency is attempting to change the way these costs are calculated as a result of the Cook Inlet Tribal Council decision and the Fort Defiance letter. So I appreciate the answers to my letter on this topic, but I hope that we can get some additional information here today. And while we're glad you are here today to provide testimony and answer questions, I think it's just so important. We need permanent leadership. We need permanent leadership at IHS. As we all know, the agency was first put on GAO's high-risk list back in 2017, and it's still there. It's critical the agency have stable executive leadership in place to make decisions and address those high-risk concerns. So this past March, the administration nominated Ms. Rosalind So, a citizen of the Navajo Nation and current director of the Navajo Area Indian Health Service, as the new director. I do believe that this is one of the last nominations for agency leadership positions to be received in the Senate. So while this is welcome news for us, I am concerned about the length of time that it has taken to receive a nomination. The annual appropriations process is never easy or quick, but it is one that we work on together. So as we look to FY23, I hope that we're able to continue this bipartisan tradition. With that, Mr. Chairman, back to you, and I look forward to the discussion this morning.
Thank you very much, Senator. Now we turn to the Honorable Elizabeth Fowler. Welcome.
Good morning, Chairman Merkley, Vice Chairman Murkowski, and members of the committee. Thank you for the opportunity to testify on the President's fiscal year 2023 budget request for the Indian Health Service. Before I turn to the fiscal year 2023 request, I want to first acknowledge and thank each of you for your work over the years in growing the IHS budget and prioritizing tribal issues within your bill. With your support, the IHS budget has grown by 57% in the last decade. And we know that type of growth is challenging to accomplish in a constrained discretionary funding environment. Patients across Indian country have benefited from your efforts. This growth in funding has enabled us to address some of the most critical issues facing the Indian health system, from addressing exponential growth in legally required contract support costs and Section 105L lease agreements, to resolving accreditation emergencies, to bolstering the core administrative functions of the agency. We know you also fought hard to tackle urgent disparities facing Indian country, such as the opioid epidemic, HIV, maternal health, and suicide prevention. Over the years, this work has always been underscored by our shared goal to improve health outcomes for all American Indians and Alaska Natives. HHS deeply appreciates this partnership and commitment. It is with this shared goal in mind that the administration approached the fiscal year 2023 budget request for the Indian Health Service. We know that despite our shared efforts, IHS is still underfunded. Whether you look at per capita spending rates compared to other federal health programs or other national health expenditure benchmarks, it is clear that current funding is not sufficient to meet the needs of the over 2.7 million American Indians and Alaska Native patients that IHS serves each year. This underfunding of the Indian health system directly contributes to stark health disparities in tribal communities. American Indian and Alaska Native people born today have a life expectancy that is 5.5 years shorter than the U.S. all-races population, with some tribes experiencing life expectancy as much as 12 years shorter than the general population. Long-standing health disparities were compounded by the pandemic, with American Indians and Alaska Natives experiencing disproportionate rates of COVID-19 infection, hospitalization, and death. Addressing these inequities is a moral imperative for our nation, and it will require bold action from all of us to ensure we are upholding our commitments to Indian country. That is why the President's fiscal year 2023 budget proposes the first ever mandatory budget for the Indian Health Service. I acknowledge that this is a substantial change that would fundamentally impact how IHS receives funding from Congress. The administration did not propose this change lightly. We believe that a change of this magnitude is needed to deliver on the government's healthcare responsibility for Indian country. This proposal is in line with long-standing recommendations from tribal leaders across the nation, including in the tribal consultation and urban confer HHS conducted last year on long-term funding solutions for the IHS. The fiscal year 2023 IHS budget is a starting point for ongoing conversations with tribes in Congress to consider and refine the proposal through the legislative process. Just to summarize, the fiscal year 2023 budget includes a total of $9.3 billion in mandatory funding for the Indian Health Service, which is $2.5 billion above the fiscal year 2022 enacted level. From fiscal year 2024 to 2032, the budget would grow automatically to account for the growing cost of providing health care, as well as population and pay growth. This budget would address the three core issues identified by GAO: funding stability, predictability, and adequacy. These changes will allow IHS, tribal health programs, and urban Indian organizations to more effectively plan and implement healthcare services to best meet their community needs. As we work towards securing stable and predictable funding to meet the needs of Indian country, we are committed to working closely with our stakeholders and understand the importance of working with partners, including Congress. Thank you again for the opportunity to speak with you today. Happy to answer any questions that you might have.
Thank you very much. And with your agreement, we'll put your entire written testimony into the record. Yep. No objections on the committee? So ordered. And let's start with this question of the mandatory funding. So it certainly does relate to having stable and predictable budget. But as I mentioned in my initial testimony, there's always some reservation on Capitol Hill to forego the oversight function. And this is set up as a structure for a 10-year period. And it's quite different from the advanced appropriation request that I championed last year at the request of IHS, and that we supported in our Senate bill. We ultimately did not get agreement in the final negotiations between the four corners, the final decision makers. But I thought that had a lot of merit to make sure Indian Health Services did not shut down during any government shutdown, which was a previous significant problem. Is it the case that the administration is dropping its request for advanced appropriations in favor of the reclassification of mandatory spending?
So the mandatory proposal for the Indian Health Service, if enacted, would eliminate the need for advance appropriations for the agency.
Okay, so the answer is yes. And how do you envision that there would be any congressional oversight under that structure?
We understand that if the mandatory proposal were to be enacted, that we would fall under the jurisdiction of our authorizing committees, which we would work with in an oversight role. But we also understand the need to continue to be responsive to the appropriations committees as well, and we would be happy to work with the appropriations committees on any questions or inquiries or any interest that they have in continuing to any questions, any interest they might have in continuing to review our budget and request information from us.
So in partnership with our colleagues from Indian Affairs, we've been trying to schedule a meeting with OMB and IHS to explore the technical details, and there's not been a responsive communication from the administration. So can we get your assurances that this meeting will happen shortly?
Yes, as I understand, OMB will be leading a briefing that we anticipate will occur next week.
Okay, great, because if the administration is not responsive, it's clear it's not a serious proposal. And so we're ready to dive into the details and explore it, but we need the partnership from the executive branch in that regard. So let's turn to COVID. So the positive test rate remains high, and we are seeing across the country stagnating vaccine rates. Are we seeing the same trends across Indian country?
We are. The positivity, we are seeing higher positivity rates, but we believe that is from more patients coming in who are symptomatic for testing and a lower volume of testing. And so as an example, in January, there were 12,000 COVID tests performed, and in April, there were 2,000 tests performed. So the positive test results combined with the lower denominator is resulting in a higher positivity rate.
No, okay, that makes sense. Thank you for explaining that. And the administration has requested $22.5 billion for COVID response, and there was no specific request for IHS, but it's my understanding that the funding requested by HHS, Health and Human Services, that a certain share would be transferred to IHS. Is that your understanding as well?
Yes, IHS is a jurisdiction that receives vaccines and therapeutics from the HHS.
Okay. Do you know how much would be transferred under the administration's vision?
It's not a funding amount that gets transferred. We receive the vaccines directly, and we receive the therapeutics and some supplies directly.
So let's talk about the therapeutics. We've got a couple companies that have produced pills, Merck and Pfizer. that seem to be significant. Are these pills being currently distributed to IHS facilities? Do people who need those therapeutics, can they readily access them?
Yes, currently we are able to meet 100% of the demand from the IHS tribal and urban facilities that are requesting those therapeutics.
Okay. You are requesting the therapeutics?
I said we're able to meet 100% of the demand from those facilities that are requesting therapeutics.
Okay, great. We've seen interesting reports across the nation from healthcare clinics that essentially have had the therapeutics, but they don't even prescribe them when people come in. It's been a strange arrangement where we've got a tool that can be very helpful in when a person is early in the phase of the infection. And not necessarily being fully utilized. I'm not talking about the Indian Health Service specifically, but more health services more broadly. Let me turn to Warm Springs water infrastructure. And as if we've discussed in the past, they've got an ancient system of pipes. The pressure gauges are always breaking, or pressure control valves. The pipes are splitting. It's just the contamination results in a lot of the times the water simply is unsafe to drink. So they've been under the continuous boil notices, meaning they have to boil their water to drink it. So we are really pleased that the infrastructure bill had $3.5 billion to clear the backlog on the sanitation deficiencies list at the time of passage. And we're looking forward to seeing the projects actually get done. Do you have a timeline for the Warm Springs project?
So the last time we talked, there was a preliminary engineering assessment that was going to be completed, which has been completed. We now know that the project will cost roughly $24 million to complete. It is a Tier 1 project, so we do anticipate that it will be funded with fiscal year 2022 funding, whether from the Infrastructure Investment and Jobs Act funding or the annual appropriation. As I understand it, it will take 30 to 36 months to complete once we have the funding available for the project, which we anticipate will be very soon.
Great. Is very soon like within the next couple weeks?
I would think so, yes.
Can you personally keep me briefed on this? It's so important to the Warm Springs tribe in my state.
Yes.
Thank you very much. I'll turn to Senator Murkowski.
Thank you, Mr. Chairman. Ms. Fowler, I'd like to go back to the discussion that the chairman has raised about mandatory versus the discretionary. You confirmed to him that, in fact, the administration has now decided to take an approach on mandatory as opposed to the advance appropriation. And you indicated that, well, if we move to mandatory, that means that we don't have to look to advance appropriations. But I guess I'm trying to understand why the administration chose to move in this direction instead of proposing advanced appropriations again.
Thank you, Senator Murkowski. I'm just going to be frank here. The Indian health system needs substantial funding to meet the needs that are out there in Indian country, and we're not able to accomplish that within the discretionary spending caps. On the mandatory side of the budget, as has been proposed for fiscal year 2023 and the 10-year time frame, we're proposing that the budget will grow by almost 300% over that 10-year period. And so we believe that it's an approach that is more suitable for funding Indian health care. Well,
as I mentioned in my statement, and as I have said over the years, I believe that IHS has been chronically underfunded, and we need to make improvements. You and I both noted in our comments that those improvements over the years have been dramatic in terms of the funding. But with funding also comes the role of oversight, and that's where the committees come in. I am in that enviable position. Maybe it's not so enviable, maybe it's just more responsibility. But I am not only the appropriator for IHS as the ranking member on this subcommittee, but I'm also the authorizer as the ranking member on Indian Affairs Committee. And so I appreciate what you've shared, that there's going to be a meeting with OMB coming up. This is the first that I have heard of it. I'm asking my staff to confirm whether they have been notified of any such a meeting, because so far as I know, there is no legislative proposal out there in terms of new authorizing language to account for this shift. And what we're trying to figure out here is whether or not you have identified how you're going to be paying for the shift to mandatory appropriations. At what point do you expect that you will send to the Indian Affairs Committee a legislative proposal to mark up a mandatory funding bill for FY 23?
I know that there's a supporting document that is under development. I will have to get back to you on that time frame of when we'll be able to submit it.
So it's, I guess I have to admit a little bit of confusion here, because what we've got is technically there's no discretionary appropriations language or money proposed for FY 2023. The discretionary funding levels for the IHS in FY 22 was $6.6 billion. So in theory, if there's not a discretionary proposal for the Interior bill this year, there's $6.6 billion that is currently unaccounted for. So, Mr. Chairman, we're looking here at $6.6 billion in base Indian Health Service funding that can't be used by an authorizing committee to pay for mandatory funding on an annual basis. It certainly wouldn't cover the scoring for a 10-year window that you've just noted. But it's also been 2 months now since the budget was released. The end of the fiscal year is a little over 4.5 months away, so the clock is ticking here. So if you're planning on sending this plan up, I don't see how you're giving us the time, as whether we are authorizing or whether we are appropriating, to consider this in a way that is viewed as a serious proposal. And so I share the chairman's concern here that if this is serious coming from the administration, if we recognize that we've got to be doing this together, you've got to be working with us a little bit more, instead of coming to a hearing and saying, well, we're going to sit down and talk with you about what the plan is. We are in the midst now of these budget and appropriations discussions. So I don't know. Is it your proposal that there be no IHS title in the FY 23 Interior Appropriations bill this year?
That is the proposal, yes.
So there would be nothing in an IHS title?
Correct.
So oversight, again, absolutely key to everything that we do around here. In fairness, I don't think we do enough of it, but I think that this is one of the areas within the Appropriations Committee where we are able to do active oversight. Will you commit to answering questions from this Appropriations Subcommittee, even though you would propose to delete the discretionary account from the Interior bill?
Yes, we will commit to that.
Let me ask about contract support costs. I've raised the issue of the decision in Cook Inlet Tribal and the Fort Defiance letter. A lot of questions and concerns. Again, we received your response last week, but there's still some things that I need some clarification on. For the record, in your letter, you state that the agency interprets the Cook Inlet decision and the Fort Defiance letter as a restatement of current law and practice. You also say that the IHS will maintain current methods for calculating CSC and that there's no plan to change any of the calculations. So the question that I would have for you this morning is, are both of those statements correct? And would you support codifying current practice in legislative texts if you would agree that those statements are correct?
I agree that the statements are correct. We're not changing any method of calculating contract support costs as a result of the Cook Inlet decision. We believe the Cook Inlet decision affirms current statute and current interpretation of the statute, and therefore we believe that there's not a reason to codify the current practice of calculating contract support costs.
So there's some buzz out there that that this may be a situation where Cook Inlet was just one example. In the case of the Fort Defiance letter, it stated that the federal government errantly overpaid CSC in prior years. They were seeking to correct it. So the discussion that is out there is whether or not the Fort Defiance issue is the only example where the federal government errantly overpaid. So the question that I would have of you is whether you know if this is the only instance in which IHS has made overpayments, and whether or not you've conducted any type of an analysis that would lead you to that conclusion.
So there's a process for reconciling contract support costs owed to tribes. We're required to fully pay the amount of contract support costs required for a tribal contract. During that process of reconciliation, sometimes there are overpayments that are identified, sometimes there are underpayments that are identified. A tribe can bring a Contract Disputes Act claim for an underpayment, and IHS can do the same for an overpayment. And there are other instances where the Indian Health Service has identified overpayments of contract support costs and has sought repayment or has sought to reconcile the overpayment through the means that are available to us.
So, Mr. Chairman, my time is well over. I may come back to this because I'm trying to determine is whether or not there's been any type of a comprehensive analysis of whether or not overpayments are at issue and the extent of that. I'll defer now to my colleague.
Thank you. Senator Heinrich.
Thank you, Chairman. Ms. Fowler, there are literally hundreds of projects representing over $3.3 billion on the IHS fiscal year 2021 annual report of sanitation deficiency levels. Projects in my state alone represent nearly $200 million in water and sanitation projects. As you know, Congress included a total of $3.5 billion for the IHS sanitation and facilities account to be spent over the next 5 years in the infrastructure law. Walk us through what the current status of actually getting that funding on the ground and how IHS is preparing agency personnel and resources to get those projects on that list built.
Thank you, Senator. When the Infrastructure Investment and Jobs Act was passed, Indian Health Service quickly planned and implemented a consultation process on an allocation method for that funding. We held some sessions in December and a session in January. So we had several consultation sessions on the funding. Once those sessions were completed, we compiled the comments, we reviewed the comments, and considered every piece of input that we had received from the tribes. We then began working on a spend plan. We also worked on a spend plan for the administrative portion of the funding and working to identify what staffing resources were going to be needed in order to implement the funding, and work to identify how we were going to hire that many staff, It's a considerable number that are going to be needed. And so we had a couple of different tracks that were proceeding. We're at the point now where our spend plan for the projects is in the last stage of review, and we anticipate that we'll be able to announce the decision that we made for which projects are going to be funded with the fiscal year 2022 portion of the $3.5 billion very soon. We are also putting...
How much will that represent in actual projects? Do you have a dollar figure yet?
Let's see, it's $700 million per year, and then there's 3%. Sorry, I'm going to ask my Chief Financial Officer. She probably has the numbers at her fingertips.
Certainly, we do expect that the bulk majority of the resources will be used specifically for project construction. There is the $21 million for admin, of course, and then the small portion of funding that goes to the OIG, who we have already started engaging with on oversight issues. But we expect...
So you're planning to largely just split it up equally over the 5 years?
Since we received the same $700 million each year, we will take a similar approach each year.
Okay. How soon do you think we can see actual work on the ground within the projects that you've selected, not trying to micromanage which projects make it into that first tranche, but when are we going to see the actual work begin?
I would say actual construction is actually going to take some time. It's going to take several months because even the Tier 1 projects, which are ready to fund, still require some additional documentation to be completed. And so that will take some months to complete. So before actual construction and on-the-ground work begins, I would say it's going to be into next year before that even begins on any project.
Okay. Let me shift gears to over the course of the last year, the Albuquerque area IHS system closed 2 hospital intensive care units, one at Acoma Canyoncito Laguna, another at Mezcalero. They did that citing lack of resources as a contributing factor to the closures. And IHS has now decreased service in both locations to only business hour urgent care centers. As you know, Congress has passed historic funding for the IHS through CARES, through the American Rescue Plan, and this budget also increases overall funding for the IHS. So I'm trying to reconcile the disconnect between the historic funding that we've passed in the last 2 years, the increase in the current budget, the increase that we heard about over the course of the last 5 years, and the disconnect between that and the lack of service at Acoma Canyoncito Laguna and at the Mezcalero site. Why are we seeing those reductions in services at the same time we're increasing overall funding?
Let me start with the Acoma Canyoncito Laguna facility. The lack of resources there was the result of 2 of the 3 tribes withdrawing and seeking to manage their own healthcare programs under the Indian Self-Determination and Education Assistance Act.
The 638 program.
Yes, the 638. So the resources that were left, that were the Pueblo of Acoma's share of that funding, of that hospital, was not enough to sustain an inpatient facility. And so we did use CARES Act funding. We did use some supplemental funding to maintain operation, ER and inpatient services at that facility for a year beyond the intended closure of the facility. But at that point, there were no other resources that were available to us to continue those services. The Mezcalero facility, the issue there is the inpatient census had been decreasing to the point that we could not accomplish accreditation as an inpatient facility. The Joint Commission would not survey the facility as an inpatient facility because there were not enough inpatients that it would consider it to be a hospital at that point. I don't think that that is unusual in very rural areas of the country. And so we started to consider what is the best way to continue to ensure access to primary health care for the tribal members who reside in that location. And taking the resources, running an inpatient facility is very expensive because you have the 24-hour support that's needed. And so we began to consider what is the best approach for some of our hospitals that were unable to achieve that accreditation that's necessary, and also to assure the quality and safety of the care that's being provided. And so we chose to shift to the urgent care model and the primary health care availability during the normal business hours of a clinic.
Thank you, Chairman.
Senator Van Hollen.
Thank you, Mr. Chairman. Ms. Fowler, it's great to have you here, and it's great to have a University of Maryland alum. Let me turn to the issue of American Indians in urban areas, because in the state of Maryland, we have 40,000 individuals who identify themselves as American Indian or part American Indian, and nearly half of that population resides in Baltimore. And as you know, nationally, 7 out of 10 American Indian or Alaska Native people reside in urban areas. And in my view, this is a population that has not received the attention or services that are deserved. That's why earlier this year, Senator Padilla and I and a few others wrote to the President and the Vice President asking the administration to form an urban Indian interagency work group. We've not gotten a response yet, so my opportunity is to ask you about this. Would you support the creation of such a work group and work with us to focus more closely on the needs of American Indians in urban areas?
The Indian Health Service considers urban Indian organizations to be a vital component of the Indian health system, and we would gladly participate and support any interagency efforts to address health care for urban Indians.
Well, if you could do me a favor, if you could, we can give you a copy of this letter that was sent by a number of senators. We would like a formal response from the administration as to whether they support our request to establish this kind of work group, which we think would be important. Can you do that for us?
Yes, we will.
All right. As you know, there's lots of concern and uncertainty with the real prospect that the Supreme Court could overturn Roe v. Wade. We don't know what the final decision is, but that's certainly what the draft decision indicates. And as you know, the Indian Health Services are the sole providers in many cases of reproductive health services to American Indian populations. We also know that the Hyde Amendment has restricted the ability of many of these women to obtain reproductive services. We also know that in the cases of rape, where the Hyde Amendment does permit the use of these funds, that has to be reported to the police within 60 days. And we also know, and Senator Murkowski and others have highlighted the fact that American Indian women have been especially vulnerable to targeted for violent crime, including rape. So I guess my question to you is, if the Supreme Court decision does knock out the right to an abortion pursuant to Roe v. Wade, what planning do you have in effect to ensure that women, including victims of rape, have access to reproductive health services?
Great question. We've actually begun some discussions around this topic. I don't have anything specific I can share with you today, but we are considering there are some regulations specific to the Indiana Health Service that we're looking at that pertain to this area. And our chief medical officer will be working with our reproductive health experts on reviewing and examining the current Indian Health Service policy and considering any updates that will be necessary.
Well, I appreciate that. We've been looking over the current policy in light of what could come from the Supreme Court, and I do think it requires updating to ensure that these women have the reproductive health services they need. I have no further questions. Thank you.
Thank you very much, Senator. That's so rare to leave a little bit of time on your clock. Thank you. Senator Tester.
Thank you, Mr. Chairman, and I'll use it. So thank you, Senator Van Hollen. It's good to have you here. Thank you very much for being here in front of the committee. What would you say the biggest challenge is for IHS right now?
Staffing.
Right answer. Thank you. We didn't have to go down this line like I did a few years ago. This budget puts significant money, $21 million additional, I believe. Is that correct, into staffing? You can correct me if I'm wrong. I'm just looking at some notes I've made here very quickly.
Well, when you're referring to staffing, is that to hire staff or is that for recruitment and retention
Well,
initiatives?
hopefully that's for both. Is it more than that?
It's
for
more
both?
than that.
Okay, good. So the question then that I would ask is that I think your priorities are correct in this budget. Staffing is a problem. Doctors, nurses, do you have a plan on how to utilize those dollars to get the biggest bang for the buck and get the people on board that you need? Because I think there was a GA report from a few years back that said you were about 25% short.
So the funding that we've requested in the president's budget is there are a number of items that are included that will be really helpful to us in addressing our staff shortages.
Okay.
From incentives, additional compensation. There's a legislative proposal to exempt our loan repayment and scholarship programs from taxes. There is not a provider, but we are proposing $18 million to establish a scholarship program with payback obligations for engineers.
And these are new programs, correct? These are programs that you haven't had in the past?
Their expansion, they're either enhancing our current programs. There are some new ones as well.
Okay. So in Montana, for example, it doesn't matter if it's in Indian country or if it's in urban clinics, we need more people. So how are you going to get out to recruit those folks? How are you going to tell them that you have these new programs out there available to them and that IHS is a good place to work?
Well, I think that part of the funding that we're asking for, if it's enacted, will help us to beef up our recruiters so that we can do more work, direct hands-on work with students. We're working to increase our residency programs. We want to get students into the Indian Health Service before they graduate so they'll be interested and come work for us. There are actually several strategies that we're already employing. Okay. We hope to deploy as well.
That's good.
Using new funding.
My advice is to be as aggressive as you possibly can. Otherwise, it's going to be hard to make this happen because the doctor shortage is everywhere. Mm-hmm. And IHS, because of trust responsibilities that we have and because it provides health care to people who really need health care. We need to make sure we're staffed up. Can you talk about the facilities line items in your budget a little bit? Are they plussed up? Because if you don't have good facilities, you're not going to be able to recruit doctors and nurses. So are the facilities line items plussed up to a point where it's adequate? And if so, tell me why.
Yes. As a matter of fact, the budget proposes to complete the healthcare facilities construction priority list that was established in 1993 within the first 5 years of this 10-year proposal. It will provide an additional $72 million for our equipment needs so that we can, when we get providers who are just coming out of medical school and coming to work for us, they're used to some bells and whistles, and they don't currently see that within the Indian Health Service. So being able to upgrade and keep our equipment updated is going to be helpful in that regard.
Okay. So you're 100% correct, and with the increases in budget also comes accountability. And so I would expect that you guys will be very transparent in how you're doing business so that we know that the dollars that are appropriated at whatever level gets to the ground, because there's a lot of need out there, both in staffing and facilities, as you already know. Can I ask, IHS did not include advanced appropriations in the 2023 budget. Is there a reason for that?
If the mandatory budget proposal is enacted, then advanced appropriations will not be necessary because the mandatory proposal will automatically appropriate the funding each year for the next 10 years.
Okay. So are you advocating, and just to help educate me on this, that this entire budget be mandatory funding?
Yes.
What percentage is mandatory funding now?
Only $147 million for the special diabetes program for Indians.
And that's how much is the rest of the?
It's a total $6.6 billion budget. So
And 147 is mandatory.
147.
So in the case of a potential government shutdown, you guys have to shut down. And if there was mandatory funding, you would not?
So let me clarify. Because we provide health care, we don't shut down. We're considered accepted. We just can't pay our staff if we don't have any other source of funding.
But that's a problem.
But yes, it is.
Okay. All right. Have you had consultations with Indian tribes on the issue of mandatory versus discretionary funding?
Yes, we have.
And on advanced appropriations also?
We've not consulted on advanced appropriations, but we've been hearing for years from tribal leaders that they desire advanced appropriations.
All right. Well, I want to thank you for being here. Thank you for your knowledge on this budget, and I appreciate the opportunity. Thank you, Mr. Chairman. Ranking Member Murkowski.
Thank you very much, Senator Tester. I want to turn to the bipartisan infrastructure bill, and one of the things that is in it is a limit of 3% for, quote, administrative costs. But administrative costs apparently includes project critical activities like the engineering, in which case the 3% doesn't make sense because the engineering is often more than that. And so like designing a new water system is a significant undertaking. I don't think of that administrative cost at all. I think it is as a core part of the construction from beginning to end to get it designed right. So I had pushed for a higher limit of 10% on this, but from your experience, is this 3% limit a problem?
It is a problem. We do not believe that it will fully fund all of the administrative costs that are necessary to implement the IIJA funding in a timely way.
Okay, well, thank you. We want to keep working with you to explore that question. Maybe the key is that engineering shouldn't be identified as an administrative cost. I mean, administrative costs, you think of payroll and communications and so forth, but engineering is not what I think of in that category. We'll continue that conversation with your team and with our colleagues here. And let me turn to the urban Indian organizations, and Senator Van Hollen mentioned the importance of that, certainly important in my state of Oregon. And we did have the increased funding of, it was 17% increase. Did more grants go out to urban Indian health organizations as a result?
We did not fund any additional urban Indian organizations with that funding, but what it will do is allow some of the programs that are currently referral-only programs to initiate services, actual clinical services to provide to patients.
Okay, we'll submit questions for the record to better understand how we're spending the additional money in that account and understanding how the urban Indian population is being better served, like what specific changes have occurred. Thank you. And Senator Tester raised the issue over staffing, significant issue. And one of the things that you testified last year was the student loan repayment program was the most effective tool you have in recruiting. Have you done specific changes to that program as a result of the additional funding for staffing?
We haven't made changes to the program, but what it does is allow us to fund more providers with loan repayment. The $5 million that's provided in fiscal year 2022 will fund 100 additional providers.
Okay, so the program remains the same, but it remains available at more locations in Indian country.
Yes.
Okay, great. Thank you. Thank you. I want to turn to the Weber report. And the Weber report, this is it's a terrible story. It's a terrible story about how there was a doctor, Dr. Weber, who abused children within the Indian health system. And we had an independent report that was commissioned by IHS that found that officials at the federal agency, and I'm quoting now from a New York Times article in October, silenced and punished whistleblowers in an effort to protect the doctor who sexually abused boys. This is like the story we never want to hear. Have those individuals who silenced and punished whistleblowers been fired?
So a number of those individuals that were involved in the Weber case are no longer with the Indian Health Service. And any individuals who were found by the Office of Inspector General to be who needed to be disciplined or should be disciplined were disciplined.
Can we get details on that?
To the extent that we're able to provide that type of information.
Okay. The report has a number of recommendations, and other ideas have also been mentioned, so I'll just quickly run through them. One recommendation of the report was you put in place whistleblower protection coordinators at 12 regional offices. Have you done this?
We have not done that yet.
Why not?
Funding. It is a resource issue.
Oh, okay. I'm kind of stunned by that answer, because if we're talking about 12 individuals in a system as large as the Indian Health Service to make sure that whistleblowers are protected, it seems like it should be a very high priority, should it not?
So the approach that we've taken to the recommendations, not only to that report, but to recommendations from the OIG, from the past administration's White House Task Force on Protecting Children, we've consolidated those recommendations. There is some overlap, but there are some differences amongst those recommendations as well. We currently have a chartered committee that has reviewed each and every one of the recommendations, determined their status of implementation within the agency. They're reviewing those recommendations that have not been implemented yet which would include the whistleblower coordinators, and they are going to make recommendations on the priority for implementing those recommendations and whether or not additional resources will be required to implement them.
All right. I'll tell you why I think, why it feels to me like this is such an important question. Because in the medical community, there is a huge reluctance to report on the conduct of any other members of the medical community. And so those who do so, it's very difficult for them to do so. And if they are not protected, if they are essentially fired, it sends a message that no one else will report. And if no one else reports, abuse occurs. And so I see whistleblower protection is essential. Now, I will, in follow-up to this hearing, ask about this long list of suggestions. And I think one of them you have implemented. There is a hotline in place. There's a number in place to call, is there not?
There is a dedicated hotline for reporting.
Great. And is that well publicized throughout the system now?
It has been publicized, but we're currently planning to increase the visibility of the hotline and make sure that it is well publicized.
Okay. And I want to get details on it, find out how many, when it went live, how many calls have come in, are they being responded to? Again, people will be reluctant to call if their careers are at risk because they share information. We have seen this issue that arises in every institution. Yeah, I mean, it's like, and it does so much damage to every single child who is abused for a lifetime that there has to be a huge priority. Another is on training, and so I'll want to get details about what you've done to implement training for IHS employees and contractors. Stronger patient safety protocols that are recommended. I'll want to get details on that. The preservation of records, which are apparently very poorly done in the past. I'll want to get details on that. And the Blackfeet Nation in Montana, which was very directly affected by Mr. Weber's abuse, is asking for an apology from IHS, and I'll want to get details on whether IHS has responded to that request. Or if perhaps you know now, you can tell me.
I don't know the status of that request.
Okay. Thank you. This should be a huge priority. Not one more child should be at risk. I mean, we keep seeing these horrific things that occur in organization after organization, like, for example, the Olympic Gymnasts Association. Like who would imagine? And so if people who are sexual predators know that they will be reported on and that those who report will be protected, it dramatically changes the situation. And one of the things I was very struck about in this article was that it said IHS management ignored or suppressed efforts to address this danger. Well, when that happens, that means more children are abused. Like 1,000% unacceptable.
Senator, I agree with you 100%. I believe we have taken many steps that are addressing the root causes of the failures that occurred in the Weber case. I believe we made many improvements, and I believe the culture is changing within the Indian Health Service, and we're happy to provide those additional details.
Thank you. Thank you. Senator Murkowski.
Thank you, Mr. Chairman, and know that I absolutely agree with your concern about this. Ms. Fowler, you mentioned that it's a matter of resourcing. Yes, it's always a matter of resourcing, but it's also a matter of prioritization. And if this was something that had just hit the news and we're responding to it, it's one thing, but it's not. It's been out there for a while, and again, I think this is where I still remain a little bit concerned about the approach the administration is taking with regards to moving over to mandatory. You still have, or you have been on the GAO's high-risk list since 2017. I mentioned that we are just now at a point where we're going to be able to take up the confirmation of the administrator for IHS, and the fact that maybe it's just a hard position to fill. I think it really is. I think it's very, very hard, but still, it makes me think that the administration doesn't place a high enough priority on it to really try to move that. And when you're going to be implementing such a really a systemic change, when you move an entire Indian health system to a new approach, and you don't have an IHS administrator in place, it makes me question whether or not you have the talent that you need, the senior executive team that you need to make some really important decisions that will need to be implemented, and implemented in such a way that it gives members who have been around these issues a long time. Senator Tester, as you know, was formerly chairman of the Indian Affairs Committee. I've been on the Indian Affairs Committee for 20 years now, and have served as the ranking member now several different times. These are issues that we all care very deeply about, but this is leadership, and when leadership is saying a whistleblowing protection is not going to be prioritized as it needs to be, doesn't give me the degree of confidence where I can say, all right, as the appropriators, we're not going to be in there on an annual basis and having the input that the appropriators do. And I appreciate what you've said, that you'll come back to the committee, but I know for a fact that we oftentimes have to use the hammer, if you will, of we're going to bring you in front of the committee to answer to you about where these funding priorities have been. I just want to add that I did check with my folks on Indian Affairs, and have been made aware that OMB is having a tribal consultation on the FY 2023 budget with tribes, but we're not aware of any other meeting out there, and recognize that OMB tribal consultation and a meeting to discuss this shift to mandatory, in my view, would be very, very different. So again, I raise this to underscore my concern. I was talking about contract support costs before I deferred to my colleague here, and I wanted to just ask a further question in this vein. The issues of contract support costs and the situation with Cook Inlet Tribal and Fort Defiance arose during a renegotiation. So what guidance have you given tribes or tribal organizations who are expected to renegotiate agreements with IHS, and do you anticipate that those agreements are going to have to go through an added level of scrutiny now that this is all transpired? What's the situation with these renegotiations in light of Fort Defiance?
The process for negotiating contract support costs is outlined in our contract support cost policy, which was developed with a tribal work group, tribal federal work group. And then we did full consultation on that policy. So we do have a policy that has been agreed upon with tribes for addressing how we, when a contract is coming to an end, how we then relook at the terms of the contract, including contract support costs.
Including whether or not overpayments have been made.
And it includes a process for reconciling the contract support costs. Because the way the process works, we pay contract support costs at the beginning of the period of performance. So at the beginning of the fiscal year, if that's the period of performance, based on the budgeted amount, and then it's reconciled against what the actual contract support cost need was once that need is known, which is after the end of the fiscal year. So there's a process in place that where it's routine and it's normal to identify whether there's an underpayment or overpayment that exists for that contract, for contract support costs.
So you don't see that there would be any additional scrutiny or anything that would slow or hinder these renegotiations then?
No additional scrutiny than the current process that we currently use.
Okay. Let me ask about 105 tribal lease payments. This is something that I raise every year before the committee, that and Village Built Clinics. We in the FY21 Omni, we all agreed to separate out the 105L costs. We created a separate appropriations account similar to what we did with contract support. Additionally, there was a general provision that was included that directed both IHS and Interior to begin this process to establish guidelines regarding the parameters for which lease agreements could be structured and paid for. But since the 105Ls have started being paid, we've seen estimates really kind of all over the board. I think wildly unpredictable, and they have certainly injected some budget uncertainty into the process. Do you consider that the 105L leases are stable and are predictable?
I would say no, and that makes it very difficult for us to identify the amount that's needed to fund them.
Which has been a frustration of mine because, again, we've got to figure it out here, and we're all trying to look into that crystal ball to understand, where we're going, what is it going to look like, and we've asked for a more reliable schedule. So then, going to the administration's FY23 mandatory appropriations proposal, you have $150 million proposed there. So is that the current up-to-date estimate for the tribal leases? Because, again, you and I have both recognized we haven't seen a level of stability, and it's hard to predict. We've seen estimates that are shifting anywhere from 10 million to 50 million in a matter of months. So what are you basing the 150 million on? And do you think that is a figure that you can actually rely on then by the time that IHS would submit mandatory funding text?
So the 150 million was based on the best information that's available at the time. So we don't know what the final amount is going to be. We don't know if there are going to be any additional tribal leases that are proposed. So it is going to be very difficult to provide a firm number for the amount that's needed. However, we do expect that the amount for both contract support costs and the 105L lease agreements would remain an indefinite appropriation because of the very nature of those two funding accounts.
So, I mean, this has been the challenge, is the ability to understand and predict what we can anticipate year over year. So if you've got a new account structure, 105L has been separated from the Village Built Clinics, but both provide funding for lease agreements. So the question for you is whether or not the village-built clinics should be funded from the same account as 105Ls, recognizing that they both provide for funding for lease agreements. Because in last year's Omni, we included report language for the IHS to include an analysis or a study on the funding levels for village-built clinics. We're trying to get a handle on that one as well. So your thoughts on whether you separate them out, and can you tell me where you may be on this report for VBCs?
We're currently gathering the information for the report, and we do anticipate meeting the deadline that was in the bill, to believe was 270 days we were provided. Regarding the two programs, village-built clinics, as you stated, is separate from the 105L lease agreements account. It's funded within the services appropriation. It operates in a different way. It's under a different authority. And so there are some village-built clinic leases that are not eligible to be funded through a 105L lease. In addition, there are some tribal programs who prefer to continue to have a VBC versus a 105L, because the VBC leases are part of their self-determination agreement on a recurring basis, that they get paid on a recurring basis, versus the 105L process, which requires a proposal and some negotiation regarding what's in the proposal. So I think there's going to continue to be a need for both the Village Built Clinics program and the 105L lease account.
Well, I don't know. I'm listening to this, Mr. Chairman, and I'm the more we have the discussions on some of these very granular details that are very, very budget specific, again, it brings me back to what the committee had thought was a pretty workable proposal in terms of advanced appropriations. And so I'm still trying to reconcile with the fact that we've seen a pretty dramatic shift in the administration's views on how they want to address the IHS budget and moving it completely to mandatory, completely eliminating the discretionary aspect of it, and also given that there are some very technical things, like we're talking about the distinction between the 105Ls and the VBCs. I'm concerned about the proposal that we have out there, and don't believe that it is fleshed out enough. Certainly, we will look forward to having conversations with folks in the administration. Last point that I will raise is we've been talking about electronic medical records for forever, it seems. Last year, finally, IHS did a data call with tribes, and I think that was good. But again, we now have to make sure that our systems are talking with one another, whether it's IHS through VA, which is a big deal for us in Alaska. We need to understand who's going to pay for any necessary upgrades to the system, whether tribes are responsible for the cost or whether IHS is planning to do this. So there's a lot more to do with implementation. But again, I think that will help with some of the efficiency that we need within IHS. Thank you, Mr. Chairman.
Thank you, Senator Murkowski, and I so much appreciate your attention to detail on these programs, because how they get implemented makes a big difference on the ground to so many people in Indian country. I want to note a last issue before we adjourn. I had requested information about purchase and referred care, or the PRC program, and was supplied with a chart that I'll ask consent to put into the record. So ordered. I looked at it and I just went, my goodness, this is a nightmare for how a person, a member of a tribe in a place like Washington, D.C., accesses medical care. And if they have a medical emergency and they have to go to the emergency room, they have to give notice within 72 hours after. They might still be very, very sick or still be in the hospital at that point to have a chance to apply. This chart says, the PRC fundings are not sufficient to pay for all needed services. So it's basically is saying we're not sure even if you get us that notice in 72 hours that you're going to get helped. And this is what's wrong with healthcare in America. When accessing medical services requires a complicated chart like this, going through I don't know what is about 12 different bubbles of checks, and while you're trying to recover from an illness or an injury. So I will have questions to follow on with about this. One of the fellows on my team is a tribal member who has brought to my attention this real-life example of here in Washington, D.C., that he would have to go to New York or North Carolina to receive care or to get a referral to another facility. So I will be exploring with you how we can make this system work better. And one of the questions I will ask about is whether tribal members are given the equivalent of an insurance card to be able to submit when they need to get medical services or emergency services in a location where there is not an IHS facility. So with that, thank you. Senator Murkowski and members of the committee. And if there are no other statements, the hearing record will be open until close of business on May 18th, 2022. Thank you. Thank you, Director Fowler. And thank you, Ms. Curtis, for your expertise and hard work to make this system work well all across Indian country.